Assalamu alaikum everyone, this is Ziad and I'll be explaining the anatomy of MSK. So, this time we've made the crash course divided into three parts and this is gonna be the first one. I'm gonna be explaining these 9 lectures and inshallah it'll be very quick and they'll all be very easy. So, let's get straight into it, starting with bones of the shoulder girdle. So, when we're talking about the shoulder girdle, we have to start off with explaining what the upper limb is. So, upper limb is part of the appendicular skeleton, meaning that, okay, we have a limb here, we have a limb here, so we have basically four of them. The axial skeleton is what's in the middle, okay? So, the, the upper limb itself is also divided into four parts. So we have over here, we have the shoulder girdle, which is our main topic for today. Then we have the arm made by the humerus. Then we have the forearm, which is made by the radius and the ulna. And then we have the hand. So let's talk about the pectoral girdle. So pectoral girdle, it is formed by it's basically a bony ring, okay? Posteriorly, it's formed by the scapula, and it is incomplete. As you can see, the scapula is not in touch with the axial skeleton, so it's an incomplete. It's incomplete at the back, but anteriorly, the clavicle articulates with the sternum or the manubrium of the sternum, and that basically is the only part of the shoulder girdle that articulates with the axial one. This scapula and the clavicle, they anchor the upper limb to the trunk, so they're basically what hold it on there, obviously along with the muscles. Now let's talk about the glenohumeral joint, which, or the shoulder joint. So it's basically a synovial ball and socket joint. It has a very wide range of motion, but this range of motion comes at a price of its stability. It is stabilized by soft tissue, so yeah, not that strong. Now, the articulation that forms this glenohumeral joint, we have the glenoid fossa over here. It's going to be off the scapula, and the head of the humerus, which from the name, it's on the humerus. Now, let's talk about the clavicle. Here we have the superior view, or we call that the smooth surface. Why is it smooth? Because if you look at the inferior one, or the rough one, you're going to see a lot of features on it, and that makes it rough compared to this one. Okay, so, and you have two ends here. So we have the sternal end, which is pretty round, as you can see. It articulates with the sternum, and it's more medial because, okay, we know where the sternum is. It's at the middle. It's gonna be medial compared to this one, the acromial end, which is flat and it's lateral and it articulates with the acromion of the scapula. As you can see here, it looks even better here in the inferior view. See how flat it is. And then now let's move on to the inferior view. We have this rough surface. We have over here the impression for the costoclavicular ligament. We're gonna talk about that later. We're gonna have this groove to fit the subclavius muscle, which is gonna anchor or depress the clavicle down. We have here the conoid tubercle for the conoid ligament and the trapezoid line for the trapezoid ligament. This is basically what I just said, but I have it written down for you. One thing that you need to know, that the superior one, or the superior surface, is going to be deep to the skin and the platysma. Platysma is a muscle, and the rough one just has the attachments, the ligaments, all that dirty stuff. The features, we've talked about them: trapezoid ligament, subclavius muscle, impression for the costoclavicular ligament, and the conoid tubercle, which we said conoid ligament. Now we have the features of the fractures of the clavicle. So clavicle is basically the most common bone to be fractured, and it usually results from falling on the shoulder itself or with an outstretched hand. So it happens usually at the junction of the lateral and middle. So if middle third. So if you divide it, okay. So now we have one third. Now we have another third and another third. This is going to be the lateral third. This is going to be the middle third. At the junction, it's gonna be the weakest, and there we have the most common fractures. Okay, so somewhere in this region we're gonna have the fracture, most likely gonna have the fracture over this end. So what happens when we fracture that is that خلاص, now the weight of the upper limb is gonna affect it and it's causing the shoulder to drop, and if something goes wrong with the fracture, it could even damage the brachial plexus and the subclavian vessels. Now, over here we have this triangular bone, as you can see. It has three borders, therefore it's a triangle, and we're gonna call this the scapula. So the borders, they're basically these flat lines. We have a superior one, we have a medial one, and we have a lateral one. Okay? And then we have three angles. The angles are gonna be these V-shaped structures. Over here it's not so V-shaped, but it's not a flat line. But we have here the lateral angle, the superior angle, and the inferior angle. We have three fossae, which is over here we're gonna have the subscapular fossa. We're gonna have here on the posterior side. Before we talk about the fossa, let's talk about this thing. So over here we have the spine of the scapula. It continues to form the acromion, which is gonna be, the tip or the point of the shoulder. But the thing about the spine is that it divides the posterior surface into two fossae, the supraspinous fossa for the supraspinatus and the infraspinous one for the infraspinatus. We're going to talk about this again later. Over here we have the glenoid cavity. It has another name called glenoid fossa, but let's stick with glenoid cavity. We have two tubercles, one above it, one below it, so we're going to name it supraglenoid, infraglenoid. And this over here is going to be the neck of the scapula. Now, let's talk about the features again. Divides it into supraspinous and infraspinous fossa. Make sure you know these because they're origins of muscles. And it forms the acromion, which remember that it forms the tip of the shoulder and articulates with the clavicle through the acromial end, the flat end. And remember that it goes from the second rib to the seventh one. And remember that three borders, three angles, and three fossae, so 3, 3, 3. Now we have arm support. So these three things, features of the scapula that we've mentioned before, they're basically gonna act as muscle attachments. So to the coracoid process, we have multiple muscles, but I'm gonna just talk about the ones that are on the arm itself. We're gonna have the short head of the bicep for the coracoid process. The supraglenoid tubercle has the long head of the biceps, and the infraglenoid tubercle has the long head of the triceps. We're gonna go over this again, so it's cool if you do not catch it right now. So let's talk about the humerus. So this is basically the largest bone of the upper limb. Proximally, as you can see, it forms the glenohumeral joint with the scapula, and distally it forms the elbow joint with the radius and ulna. Now let's talk about the proximal humerus. Even though it might look complicated, but it's very simple. So let's start off with the bony projections of it. We have this lateral bony projection, and we have this anterior bony projection. So the lateral one is kind of bigger, so we're gonna call it the greater tubercle. And if one is bigger, the other tubercle is gonna be the lesser one or the smaller one, so this lesser tubercle. Between them you have a groove, and if it's between two tubercles, it's gonna be called the intertubercular groove. Now it has another name called the bicipital groove. Why would it be called the bicipital groove? Because over here, the tendon of the long head of the bicep just goes over there and it goes above it, so it can go and attach to the supraglenoid tubercle. Now here we have two necks. We have the anatomical neck, which circumscribes the head of the humerus, and you have the surgical neck over here, which is, we get a lot of fractures over here, and these fractures can end up damaging the axillary nerve or the posterior humeral circumflex arteries, and they have this deltoid tuberosity over here where, from its name, the deltoid attaches. So, the surgical neck fracture is the most common one to happen, and we already talked about the things that get damaged. But we have this thing. This is not really a fracture, it's called avulsion. So it's a fracture, but we have the tendon pulling it, so we're just gonna call it avulsion. When does that happen? Shoulder dislocation, it might happen. It might happen in forceful abduction flexion injuries, and the attached muscles just pull it. So, I mean, the muscle that, the tendon just pulls it. So the other muscles that are connected to the humerus, they're gonna pull it medial rotation. As you can see, it's moving in front. It's gonna be towards the axial part of the skeleton. Now let's look at this X-ray and start identifying the things because might come in OSP, might come in SAQ. So over here we have the sternal end of the clavicle, which we said manubrium of the sternum, just kind of goes there. And then here we have, obviously this is the clavicle. Here we have the acromion end, the acromial end, which goes and attaches to the acromion. Here we have the scapula, it has its coracoid process. Here we have its glenoid cavity, which we said makes the glenohumeral joint with the head of the humerus. Here we have this, if you had to take a guess, this would be the lateral border. It's very easy to spot. Here we have the medial one, and let's go to the humerus now. So here we have the anatomical neck. As you can see, it is very much around the head. And here we have the lateral bony projection. That's going to be our greater tubercle. And then we have here the anterior bony projection. And that's going to be the lesser tubercle. Over here we have the surgical neck, which is basically the most commonly fractured site. Moving on to this one, this is the most common clavicular fracture, as you can see. This is gonna be like the middle third, I mean the medial third. This is the middle one and this is the lateral one. See how at the junction it's broken? So there's a muscle that pulls this part up. As you can see, why is it so up? Look, okay, I get that it's fractured. But why is it up? Because of the muscles that pull it. Now, what muscles? To be specific, the sternoclavicular, no, not sternoclavicular, the sternocleidomastoid muscle. Over here we have this guy. So if you did not spot it, but there is a fracture over here. This is gonna be a physial fracture. So it's kind of around the anatomical neck of the humerus, not the surgical one. Over here we have the shoulder X-ray. This shoulder X-ray is from Olena. So I just added it here to get it over with. Now that we're done with the lecture, let's go into the questions. So, fracture of the surgical neck. We said that an artery and the nerve get damaged. So here, which artery do you think gets damaged? One, two, three. I'm gonna reveal the answer now. It is gonna be the posterior circumflexohumeral artery. The nerve would have been axillary. So keep that in mind. It's very high yield. I'm so sure it's gonna come. Now, for the other question, we have here radiology, which we just took. Basically, the tip or the point of the shoulder is fractured. So, which of the following bones is going to be fractured? I'm going to reveal the answer in one, two, three. It's going to be the acromion. I've mentioned it, but as a small text, but I hope that was enough. So, this is the end of the first lecture. Now, we're going to move on to the second one. Okay, so now let's talk about the joints of the shoulder region. So I'm gonna take you guys back to FND. We're gonna talk about the classifications of these synovial joints. So we have non-axial, uniaxial, biaxial, and tri or multi-axial. Even it's called polyaxial. The non-axial will have like the plane joints and the carpal bones and the tarsal bones of hand and foot respectively. The uniaxial joint, they're going to be like the pivot ones. So in your neck, when you say no, that's going to be the pivot joint being used. And we have this hinge joint over here of the elbow. That's also uniaxial. Biaxial, we're going to have the condyloid or ellipsoid joints. And we're going to have basically, it's the wrist joint, that's condyloid. And then saddle is like the thumb. For the triaxial multi-axial, it's basically like the ball and socket joint of the shoulder. This is basically what I just said again, but in words, if you're more of a word person than, someone that likes to hear it. Just quickly look at them, get used to them, because we're gonna need them for the other lectures. So, now, after we've finished classifying these joints, let's talk about how they move. So when we're talking about the movement, we have to look at the axes of the movement. I'm gonna start by explaining this axis Z, or Z-axis, or the sagittal one. As you can see, it is sagittal. So this is the sagittal plane. We're gonna take it just as an axis, not the whole plane. And when we're talking about the movements that are related to it, we're gonna be moving around it. Okay, keep in mind this is gonna be 3D. It's not, 2D. So we're gonna be moving around it. So if we were going like this, what would you call this movement? It would be abduction. And this movement over here, that would be adduction. So abduction, adduction, we're moving around the z-axis. And then we have this x-axis or the frontal. So you make the axis on yourself and then you move around it. Okay, so we're gonna be moving in a circle around it. So if we go like this in front, that would be flexion, as you can see right here. And if we move behind this axis over here like this, that's gonna be extension. Now let's move on to the vertical or y-axis. We're gonna have here external and internal rotation. Instead of saying external, we can say lateral, and instead of internal, we can say medial. And then we're gonna have circumduction, which is a combination of movement. So the frontal one, we said flexion extension. As you can see, this is flexion and extension of the arm. Over here we have the abduction, adduction of the arm, and which is that it's gonna be sagittal or z-axis. Another movement that's like this is gonna be the inversion and eversion. So again, just make the axis down near your foot for the sagittal one, and you're gonna notice, okay, I'm moving around. If I move my feet like this, I'm doing inversion, eversion. That's gonna be around the axis. Then I have this lateral flexion or bending. So if you make it like right here, the sagittal is gonna be like this. Okay, it's gonna be like this over here. So if you're gonna be moving around it, it's gonna be like this. Okay, so let's go back to the picture so you can just relate it. Here we have the sagittal one, as you can see over here. So when you're laterally moving, you're gonna be moving like this. This is lateral flexion or bending of the body. So let's do it again over here. We have it's going towards us, so basically imagine a line going towards you and you're moving around it. So as you can see, it moves around it. The reason I want you to focus on lateral flexion or bending is because it is not similar to the rotation of left or right. The rotation to left or right is going to be vertical, but the flexion or bending, that's going to be what? That's going to be the z-axis, the sagittal one. Okay, so for the vertical one, we have this lateral and medial rotation, which we said internal or external, and then we're gonna have pronation and supination. So for circumduction now, it's basically a combination of all these movements, and it's possible in the ball and socket, saddle joints, and you can include to them the condyloid ones. So now let's talk about the joints of the shoulder region. We have the sternoclavicular one, this acromioclavicular one, and the glenohumeral one. So for the sternoclavicular joints, I know this looks like a lot, but we'll finish this so quickly. So as we said before, the only thing that holds the upper limb to the axial skeleton, or the only bone thing related, it's gonna be the sternoclavicular joint. We have over here, this is the capsule. In the capsule, it's gonna be divided into two, what's it called? Two cavities. Okay, so the reason that we have two cavities in this joint is because we have this thing called the articular disc. It divides it into two, and then every joint, this one is the saddle joint. Every joint is gonna be reinforced by some ligaments. So if we're talking about superior reinforcement, that's going to be our interclavicular ligament. If we're talking about anterior or posterior, which is not shown in this picture, sternoclavicular ligaments, they're going to be doing respectively anterior, posterior reinforcements of these joints. We have over here this costoclavicular ligament. It does not reinforce it, it stabilizes it. Reinforcement would be covering the capsule itself, or basically making the capsule stronger. But stabilizing the joint would be holding it down to something else, like here, costoclavicular, from the costal cartilage to the clavicle. Now let's talk about this joint. This joint is so stable, okay? It's so stable to the point where you're more likely to fracture it than dislocate it. طبعا بعد الشر عنكم. If this joint dislocates posteriorly, they're gonna compress this major vessel, which is gonna be the subclavian veins, and the trachea. So they're gonna be like, okay, patient fell on his shoulder, and now he can't breathe as well as he did before, or is breathing very difficulty. So what any problem in breathing? So the answer should always be sternoclavicular joint dislocation, not fracture, dislocation. Now let's talk about this acromioclavicular joint. It has, this is the joint obviously over here. It is reinforced, again reinforced means covering the capsule or making it stronger by the acromioclavicular ligament, and it is stabilized by the coracoclavicular ligament. Without this stabilizing ligament or the coracoclavicular ligament, we would experience shoulder dislocation. And this type of joint is going to be plain joint, so minimal location, minimal movement. Uh, Now let's talk about the shoulder separation again. So this acromioclavicular joint is going to be dislocated. That means we have shoulder separation. If you fall on an outstretched arm, on the point of the shoulder. So on the acromion process, uh, we're gonna have the shoulder separation. Mainly, the ligament that gets torn is the coracoclavicular. The glenohumeral joint is basically the shoulder joint, and it's a synovial ball and socket joint. It has this fibrocartilage thing called the glenoid labrum. It deepens the glenoid cavity. We have these rotator cuff muscles. We're going to talk about them later. They support the joint on everywhere except inferiorly. And then this joint is responsible for 2/3 of the possible flexion and abduction. The serratus anterior trapezium do upward rotation over here. Okay, this is very high yield. They're going to ask us a question about this. Now let's talk about the capsule and ligaments. They're attached to the anatomical neck, so over here, not the surgical one of the humerus, and the glenoid labrum. We're gonna have the glenohumeral ligament, as you can see over here. It's gonna be doing the anterior support. We have this coracohumeral ligament doing superior support, and the rotator cuff everywhere except inferior. Now, this thing over here, the subacromial bursa, it's going to be separating the rotator cuff from the deltoid and the acromion. So it's going to be somewhere right here. And then this is the acromion, and above it we'll have the deltoid. And then the rotator cuff, not forget this part. I've got it from AI, but because it wasn't so clear what bridges as the transverse humeral ligament. But what I want you to know is the bicipital groove. It is bridged by the transverse humeral ligament. According to AI, it said that was rotator cuff. So I guess let's go with that. Subacromial bursitis is basically inflammation of the bursa. It is often due to this calcific supraspinatus tendinitis, and that's going to cause us painful arc of abduction. It's going to be mentioned again in part 2, I believe, one of Atif's lectures. Tear of this supraspinatus tendon is going to cause the same symptoms. Now let's go to shoulder dislocation. The glenohumeral joint is the most frequent dislocated large joint. So large joint, most frequent, that's going to be the glenohumeral. And it goes anterior inferiorly because of the lack of inferior support from the rotator cuff muscles. So it's going to go into subcoracoid position, so under the coracoid. As we can see here, this is the coracoid process. The humerus is just went inferiorly, and we need another thing to know if it's going anterior or not. Over here it's given with this arrow, so it goes anteriorly. Now it's right under the coracoid, so subcoracoid. Now we have shoulder abduction. Supraspinatus initiates the abduction and it's innervated by the suprascapular nerve. Deltoid and teres minor, they basically take off from the supraspinatus and they continue it, and they're innervated by the axillary nerve. This is mainly the action of the deltoid, not teres minor, but it was included in the slides. They're both biaxillary, 15 to 110. It could say 90, that would still count as the movement of the deltoid. Now, anything from 90 or 110 and just takes it all the way to 180, that's going to be upward rotation, and that's going to be done by the trapezius and serratus anterior, which we talked about before. Their innervation over here. So we have the trapezius gets the accessory nerve of cranial nerve 11, and the long thoracic nerve of the serratus anterior. This is very important. This is low yield. You can know it if you just want to know it. Here we have a CT scan. We have here pectoralis major. Obviously, this is the manubrium of the sternum. Here we have the pectoralis major. Behind it, we have the minor. Here we have the subscapularis. Over here we have the latissimus dorsi. Here we have supraspinatus, as we can see here. Yeah, this is the scapula. This would be supraspinatus. Here we'd have infraspinatus, and over here we have the teres minor. These two things, they're part of the trapezius. So we're done with this. Let's get into the questions. So we're looking at the radiograph, and the only bone articulation that holds the upper limb to the trunk. What joint am I looking at or evaluating? So this is very obviously, I'm going to reveal the answer. 1, 2, 3. This is going to be the sternoclavicular joint. So the sternum, the clavicle, that's the only joint that goes in it. If you talk about like humeroclavicle, that does not exist. Coracoclavicular, that does not exist. This exists, but it's not really the upper trunk. And the glenohumeral, that's our shoulder. So now we're talking about this guy that fell out the bicycle with an outstretched hand. He has shoulder separation due to tearing of a strong ligament that stabilizes. Stabilizes, not reinforces. That ligament now, I'm gonna reveal the answer in one, two, three. That would be the coracoclavicular ligament. And this is it for this lecture. We're gonna move on to the pectoral region and axilla. Okay, so we're now gonna talk about the pectoral region and the axilla. We'll start off with the muscles. So the insertion and origin, I've made sure that they're correct, as you can see in the image. I've kept them there as a precaution in case, you know, the doctors backstab us, but the doctors, most of them said that it's not coming. So, what is left for the muscle to know? We need to know the nerve and the action. So for the pectoralis major, it takes both the lateral and medial pectoral nerves, and as you can see from its insertion and origin, if it was to contract and shorten, it can cause, you know, it can cause adduction of the arm, so bringing it closer. It can assist with the flexion of the whole arm, so pulling this thing up, or it can even medially rotate the arm after, you know, you tuck it in. So it helps in all of these. I'd recommend, you know, trying the actions on yourselves, so, you know, you get used to this, you memorize it, it's easy when you see it as an MCQ. Now, for the pectoralis minor, I'd say this one is important to know that it goes to the coracoid process and then to the third, fourth, and fifth ribs, because there's an artery that runs there, and we need to know, you know, the axillary artery, we're going to talk about that later, but know the coracoid process and the origin being third, fourth, and fifth rib. Now, its nerve is going to be the medial pectoral nerve mainly. There is a little bit of the lateral, but mainly the medial pectoral nerve. Now, what it does is that it depresses the scapula. By depressing, we mean that it brings it closer to the cage. It can even elevate the ribs, so it can either pull this down or pull this up, and it stabilizes the scapula to the thoracic cage. Now we have this little muscle here called the subclavius, under the clavicle, subclavius. Uh, it originates from the junction between the first rib and its costal cartilage, and it inserts into the inferior surface of the clavicle, which would be the subclavian groove. Its nerve is nerve subclavius, and what it does is that depresses this part, the lateral part, and it anchors the clavicle. So for the serratus anterior now, uh, the origin is going to be the upper 8 ribs, and it's going to insert into the medial border of the scapula. Now, its nerve and action, it's innervated by the long thoracic nerve, and what it does is that it helps us with the abduction of the scapula with the arm. So it causes upward rotation of the scapula. So when we're going above that 110 degrees, it's going to make sure that, okay, abduction is going to work by moving the scapula. And it's also going to do this thing called protect the scapula. So protraction would be pulling the scapula forward, bringing it to the cage. Or not just pulling it to the cage, but also pulling it outwards. So not letting it go very immediately. Now, there's this condition called winged scapula. So when you're doing a radical mastectomy, you could damage this nerve, which is called the long thoracic nerve. It runs from here like this. If this nerve was damaged, you'll have paralysis of this muscle, which is the serratus anterior, and it causes winged scapula. Now, on this, what do you need to know about the winged scapula? Now, from its name, it looks like a wing, and you need to make sure that you know that the medial border goes lateral, so out and posterior, so this direction and towards us, or you know, towards where the image is facing you, from you know, out of the screen. Now let's just talk about the muscles of the back, the superficial muscles of the back. We have this trapezius muscle. It is innervated by the spinal accessory nerve, C3C4. It doesn't have a specific name, but it's called spinal accessory nerve, C3C4. And we've divided it into 3 parts. So we have these superior fibers. If they were to pull up, they would pull up the scapula. We have these middle fibers, and they're, you know, basically they're doing the opposite of protraction, which is done by the serratus anterior. They're doing retraction, so pulling the scapula together to this line. So when you're in the gym and you're working out, the main thing that you need to do to make sure you're working out this muscle is the scapula going backwards. So you're squeezing the muscle, kind of. And then we have the inferior fibers, the ones that are down here. They depress the scapula. They make it go down. And as you can see, the origin is this occiput spinous process. So the occipital bone, or the protuberous of the occipital bone. It's right there, that's the origin. And there's, you know, they call the trapezius the muscle of the spines. Why? As you can see here, it's attached to the spinal cord by the spinous process of the vertebrae, and it is inserted into the spine of the clavicle. So, I mean, the scapula. So, Here's one spine, and then the spinous process, that's two, and then three, the spine of the scapula. So yeah, muscle of the spines. Over here we have levator scapulae. It's gonna come from the transverse process, not the spinous process, but the transverse ones from C1 to C4. It's gonna go to the superior angle, you can say, but you could say medial border would be better instead of superior angle. It's innervated by the dorsal scapular nerve and the same nerve that innervated the trapezius, which is the spinal accessory nerve, C3, C4. And as you can see from how it's attached, what it does is that it elevates the scapula up. Over here we have the rhomboids. The one on top would be the minor, as you can see here. And then the one down over here, that's going to be the major. So it's always minor over major. They're both innervated by the dorsal scapular nerve, and what they do is that, okay, they adduct the scapula, they pull it back. As you can see here, we have the origins, they kind of take off from each other. So for the rhomboid minor, we said that it's above. It has C7 and T1, so between them, C7, C8, T1, the spinous process of that. And the origin of the rhomboid major is going to be T2, T5. Okay, so basically C7, T1, and then continue from that till T5. That's going to be the origin of the rhomboids. The insertion is going to be the root of the spine. So basically, this is where the spine starts, so that's going to be the root. And then for the major, it's going to be the medial border. Another name for the medial border is going to be the vertebral one. So vertebral border. Now we're going to talk about the biggest muscle on the back, the latissimus dorsi. It is innervated by the thoracodorsal nerve, and it does three things to the humerus: extension, adduction, and medial rotation of the humerus. The reason that it can do all these actions is because it's just, inserted into the groove itself. So into the floor of the bicipital groove. And that kind of gives it, the ability to do all these actions at once. Now for the deltoid, we have divided it into the anterior and middle and posterior fibers. Each of them does its own action, but they all have the same axillary nerve supplying them. Now the abduction of the arm, it's done by the middle part, obviously, and then there's also adduction. The anterior fibers, the thing that they do is that they help with the flexion of the arm. The posterior fibers, they help with the extension of the arm, and it also the anterior ones help rotate it medially. The posterior ones help rotate the arm laterally. Now we have the supraspinatus. It is up there. The nerve and action. The nerve is going to be the suprascapular nerve, which goes through the suprascapular notch, and it innervates both the supraspinatus and the infraspinatus, which we're going to talk about. Now we did talk about the fossa, so that's going to be the origin of this supraspinatus. Same thing goes to the infra one. It's going to be the fossa. But now for the insertion, this one is going to be the superior fossa of the greater tubercle. It's not really shown that well, but in this picture, you can see how, okay, this is the greater tubercle. It is the more, lateral bony projection of the humerus. So it's going to be on the superior facet. In the middle facet, it's going to be the infraspinatus, and even lower than that, in the inferior facet, that's going to be the teres minor. Okay? For the supraspinatus, it does the same action, which is abduction of the arm, and it is also innervated by the suprascapular nerve. Where is it? Right here, the infraspinatus. Also, addition to that, it does rotation of the arm laterally. So go over here. The infraspinatus, if it pulls back, it can do this lateral rotation. Basically, make sure it goes out. So, to some degree, it helps with abduction, but I'd say throw that out the window. Focus on supraspinatus being the abductor over here. As you can see here, middle facet. So we're going from superior, middle, and now inferior facet, which is going to be the teres minor. It is also supplied by the axillary nerve, like the deltoid, and it does lateral rotation of the arm, same as this muscle, the infraspinatus. Now we have the subscapularis. It is over here. It's basically the anterior part of the scapula. It's right there. It's the third fossa and the last fossa of the scapula, the subscapular fossa. It is innervated by both the upper and lower subscapular nerve. The lower subscapular nerve also goes to the teres major. We'll talk about that in a minute. Now, what this muscle does is that it brings the arm back, so it does adduction of the arm, and it rotates the arm medially, so it brings it back towards us. So that's what the subscapularis does. Now, over here we have the teres major. As you can see, lower subscapular nerve does the same action of adduction of the arm and medial rotation. Now, let's just combine the muscles into groups. We have the abductors, so these are the main abductors, the supraspinatus and the deltoid. The supraspinatus helps us initiate the first 15 degrees of abduction, so it helps us with initiation. And again, it has different innervation from the deltoid, so you're gonna have to be able to differentiate, okay, a problem in initiation, that would not only be the supraspinatus muscle, but would also be a completely different nerve, which is the suprascapular nerve. If it was a problem after initiation, then that would be the axillary or, the deltoid muscle itself. Now over here, let's talk about the supinators. By supination, we mean lateral rotation. So that would be our teres minor and infraspinatus, the guys on the middle and inferior facet of the greater tubercle. Over here we have the pronators. So pronation happens due to medial rotation. We have the teres major and the subscapularis, both innervated by similar nerve. Here we have the upper and lower subscapular nerve. Here we have the lower subscapular nerve. Another muscle that also does medial rotation but was not grouped in this, I don't know for what reason, would be the pectoralis major. Over here we have this axilla. Okay, so axilla, when we talk about the axilla, let's think of a pyramid. Okay, a pyramid has an apex, and for us, this axilla has an apex that's between the rib and first clavicle and the superior edge of the subscapularis. So if we go back, this is subscapularis. This over here would be the superior edge. So between this, the first rib and the clavicle, so over here we would find the apex in this area. uh, the base, which is cut off here, but it would be covering this area, would be the concave skin, the subcutaneous tissue, and the axillary fascia. The axillary fascia runs from the arm to the thoracic wall. And then the apex, it's also an entrance from the neck to the axilla. This entrance, we'll call it the cervical axillary canal. So cervical, neck, axillary, which is the axilla, canal. Now let's talk about the walls of the axilla. Let's start with the anterior one. So the muscles that are over here, they're gonna form the anterior wall. So that's pectoralis minor, pectoralis major. Just add to that this fascia called the clavipectoral fascia, clavicle, pectoral, clavipectoral. Posteriorly, we've talked about the muscles. We have subscapularis, teres major, and latissimus dorsi. So the muscle that sits on the anterior part of the scapula, and these two muscles that come from the back and they insert on the humerus. So that also makes the part of the posterior wall of the axilla. Now over here, we have the medial wall. It is gonna be the upper 4 to 5th ribs. So upper 4 to 5. So from first one to either 4th or 5th. And there are the spaces between them and the muscle on them, which would be the serratus anterior. Now, for the lateral one, it would be literally the groove on the humerus. So it would be the intertubercular groove or the bicipital groove of the humerus. Now, for the contents, there are axilla, axillary, 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 but there's this brachial plexus, and we're gonna talk about that next. Basically, this brachial plexus, the roots are mostly cervical, and they go and supply this brachial, or if you want to call it, just let's say the upper limb. So it has to pass from the neck down to the arm through the cervical axillary canal. The rest are just axillary vessels, axillary lymph nodes, and a sheath. Over here we have the artery. So the artery at the lateral part of lateral border of the first rib is going to be called the subclavian. It's continuous with it. And as it goes to the inferior border of the teres major, this would be latissimus, but teres major is somewhere in here. As it goes towards the lateral border, it is gonna become the brachial artery instead of the axillary. So over here we have the axillary artery. It's behind pectoralis minor. So pectoralis minor would run from here. So here you'd find the coracoid process, and it would run like this to the third, fourth, fifth rib, and this pectoralis minor, it would divide it into medial, deep, and lateral parts. So three parts. We have three parts of the axillary artery. The second part basically makes sure that the cords. So when we're talking about the cords later on, they're all gonna be related to the axillary artery. Let's save that for the brachial plexus lecture. Over here, this is the axillary artery, a better picture. So the first part gives us one branch. The second part gives us two branches. And the third part gives us three branches. Now, for the first part, we have this thing called the superior thoracic artery. It goes here, as you can see, it's moving on the second rib. This one would be the first. This is the second. It goes on here, and it supplies both of these spaces. So it supplies the upper and so the upper two spaces, intercostal spaces. Now we have the second part. It gives us these two branches. We have the lateral thoracic artery. This goes and supplies the serratus anterior and the breast. And then we have the thoracoacromial artery, which gives us like four branches to supply the deltoid region or the pectoral region. So pectoral, clavicular, acromial, deltoid. All of them just to supply this whole region that we're looking at. Now we have the third part. It gives off three branches, as we said, but one of the branches gives off branches, and that branch is the scapular artery. As you can see here, the scapular artery kind of gives us the circumflex scapular, and it continues as thoracodorsal. So it gives us these two arteries. For the thoracodorsal, it continues with the thoracodorsal nerve that we talked about already, and that goes to the latissimus dorsi. For the scapular circumflex artery, that goes to the triangular space. We're gonna talk about that just in a minute. And we have these two other branches, the anterior humeral circumflex and the posterior. The posterior one goes through the quadrangular space, and it goes to the surgical neck of the humerus along with the axillary nerve. Over here we have this anastomosis. So basically, if the subclavian or axillary artery get occluded, we can still bypass that. How can we bypass that? Through the anastomosis that are between the thyrocervical trunk and the the subscapular artery. So over here I've color coded it, so you know what branches come out of what arteries to form these anastomoses. Do you have to know that, okay, transverse cervical comes from thyrocervical? No, but it kind of makes it easier. So we have this thyrocervical trunk. It gives us two arteries. It gives us the transverse cervical artery and the suprascapular artery, which goes into the suprascapular notch. Here we have the subscapular artery itself. It participates on those anastomoses, and it gives us the circumflex scapular artery, which also goes into these anastomoses. Now, if you were to ligate this artery, you ligate between these two things. You do not ligate before the trunk or after the scapular artery. So always ligate in the middle, not distal to the subscapular, not proximal to the thyrocervical. Now, for the lymph nodes, they drain the upper limb, the upper trunk, and 75% of the lymph that comes from the breast, or to be more specific, the lateral quadrant of the breast. And it has five groups, but these five groups all end up draining into the subclavian lymphatic trunk. Over here, we have the groups. So we have over here, if we're talking about the axilla, the lateral part would be the humeral one. So, you know, the bicipital groove. So the lateral nodes, we call it humeral. The anterior nose we call it pectoral because, as we said, the anterior wall of the axilla is made by the pectoralis major minor and the clavipectoral fascia. Over here we have the most posterior nodes, which we're gonna call the subscapular nodes, since that makes the posterior wall of the axilla. And then if we go above that, we're gonna have a node that's in the center of the axilla. We're gonna call it the central nodes. So a group of nodes right there, we're going to call them central nodes. And then at the apex of the axilla, we're going to call that the apical node or apical nodes. And then at the end, subclavian lymphatic trunk. Over here, we're going to talk about the breast cancer. So these pectoral nodes, they lie with the lateral thoracic vessels. And basically, they drain the lateral quadrant of the breast and the anterior thoracic wall. So if a patient comes to you with a breast cancer from the lateral quadrant, know that it's going to affect these axillary lymph nodes first. And this is very important, so keep it in mind. Now let's talk about the spaces. We're going to start with the quadrangular space. As we see quadrangular, that means it's going to have four boundaries. Superior one is going to be teres minor. So if you're at dental lab, you're going to know this thing. I'm going to show it again as a muscle and you can relate them together so you can, easily do it in the exam. Over here, superior border is going to be teres minor. That's posteriorly. If we were looking at the space anteriorly, instead of teres minor, we would have subscapularis. And then the inferior one would be teres major. If we were looking at it posteriorly, it will always be teres major. If we were looking at it anteriorly, it would be the latissimus dorsi. The lateral border would be the humerus, and the medial one would be the longus of the tricep. The things that go into this space or through this space would be the posterior circumflex humeral artery and vein, and we'd have the axillary nerve, and they go to the surgical neck of the humerus. So any fracture there affects these two. These are the muscles, teres minor, teres major, the long head of the tricep, and then the humerus. Over here, we're going to talk about that triangular space, which, as we said before, it has the circumflex scapular artery, but also the vein comes along with it. It has the same concept when we were talking about the superior and the inferior borders, but now we've changed from a quadrangular space to a triangular space. So it's going to have three borders only, and instead of having the lateral one being the humerus, it's going to be the long head of the triceps. Now here we have the triangular interval. It's gonna accommodate the profunda brachial artery, which is the deep brachial artery, and the radial nerve, which goes through the groove. We're gonna talk about the groove later. Uh, the Obviously here we have this lateral border. This lateral border would be the lateral head of the triceps, and this medial one would be the long head of the triceps. Now we have the rotator cuff. Mnemonic for that is sits. So the supraspinatus, infraspinatus, teres minor, and subscapularis. These are the rotator cuff muscles, and they're separated from the acromion and deltoid by this subacromial bursa. So now we're finished the lectures. The lecture. Let's go into the questions. So I'm gonna reveal the answer in one, two, three. The answer would be the deltoid. So we're not asking what nerves go through there, but we're asking what does that nerve supply. So first of all, what nerve is it? Axillary, and the muscle that it supplies is the deltoid, at least out of there. If teres minor was there instead of the deltoid, that would also be correct. Now for this question, I'm gonna reveal the answer in one, two, three. The answer is teres major. We're saying not C damage. So if it's a rotator cuff tear, not C. The only one that's not part of the rotator cuff is going to be teres major. And that's it for this. We're going to move on towards the elbow joint and the forearm. Okay, so now we're going to move on to the elbow joint and the forearm. So, we've already oriented ourselves with the upper limb. We've talked about the parts, but we're gonna now specify the part that, we're gonna now talk about the specific part. We're gonna focus on the elbow joint, the radius and the ulna, and we're gonna talk about the shaft of the humerus. We've already talked about the proximal one, now we're gonna talk about the shaft and the distal end. So, for the shaft of the humerus, we have this anterior view of it. We have this tuberosity on here, which is called the deltoid tuberosity. This deltoid tuberosity serves as an attachment for the deltoid. It's the insertion for the deltoid. And if we go posteriorly, how do I know that this is posterior? Look at the condyle of the humerus. If you can see these things, like look at the structure, the capitulum and the trochlea, I'm gonna talk about it again later, or just in a minute. If you look at them, you should be seeing them anteriorly. If you see this big fossa, which is going to be called the olecranon fossa, that means this is the posterior view. So in the posterior part or the posterior shaft of the humerus, we have a groove over there that kind of goes oblique, and the radial nerve runs in it. So we will call it the oblique radial groove. So the radial nerve can pass through it. And then this shaft of the humerus just goes, as it continues down distally, it gets wider and wider. As it gets wider and wider, it forms these supracondylar ridges. So you have a medial one and a lateral one. And these supracondylar ridges at the end, they form these epicondyles. We have the medial epicondyle, which is going to be larger and more prominent, and the lateral epicondyle, which is going to be smaller. But both of them are palpatable. And then we have the condyle of the humerus, which is formed by the capitulum and the trochlea. Here, basically, what I've explained, it's just in words. Again, capitulum, trochlea. The capitulum basically is for the radius. If we want to be more specific, the fovea of the radius. And then we have the trochlea over here. It goes from anterior to posterior, and it continues with the ulna. We have here three fossae on this humerus. Two anterior, one posterior. The radial fossa, from its name, it's gonna allow the radius or the radial bone to go there. And then from this one, the coronoid fossa, as you can see here in this image, there is this process over here. This process called the coronoid process of the ulna. This process fits into that space. And over here we have another process of the ulna. It's called the olecranon. It is basically what makes this back of the elbow, if you want to call it that. and you can easily palpate it as well. It fits into that space. Now, these are the fossae again. Now, let's talk about the radius itself. Now, this rule that I'm just about to say, it only applies for this, for the radius and ulna. So, here we have on this radius, we have the radial tuberosity and the ulnar notch over here. So, when we have a tuberosity, it is going to be on the bone itself. So, radial tuberosity on the radial bone. But when we say radial notch, that's not going to be on the radius. That's going to be on the ulna. So basically, think of the notch as something for the other bone to fit in. So if we said radial notch, which allows the radius to fit in it, it's not going to be on the radius itself, but it's going to be on the ulna, which I'm just going to show you in a minute after explaining the ulnar notch again. Same concept, head, not head, just part of the ulna goes over there, the distal end of the ulna. Now this radius, it has a fovea over here, it has this head, it has a neck under the head, and this tuberosity, the radial tuberosity. Over here, this is the ulna. Now, as you can see here, ulnar tuberosity, and then it has this radial notch up there for the head of the radius. As I said, this works as, as like something to hold the radius. So it is not going to be on the radius itself, but it's going to be on the ulna. This, just makes it easier for you to memorize it. It's going to be more understanding than memorizing. Now, if it's not obvious enough, the radius is smaller and shorter, and it's more lateral, while the ulna longer, more medial. And as you can see here, this is the coronoid process that we talked about. It has this trochlear notch, so it can, articulate with the trochlea. And posteriorly, it has this olecranon process to, fit to the back of the humerus. Now we have this interosseous border. It is found on both bones. It's a sharp margin. Uh, it serves as an attachment for the interosseous membrane. Now this interosseous membrane basically connects these two bones and it transmits force. So it makes sure that, not too much force overwhelms these bones and we have good stability during pronation and supination. Here we have these processes at the end. So the most distal process, we'll call that the styloid process. This is the ulna, so that would be the styloid process of the ulna. This is the styloid process of the radius because this is the radius. They work as attachment for ligaments that support the wrist, and we're gonna talk about the wrist later on. So surface anatomy, these three structures, the medial epicondyle, lateral epicondyle, and the olecranon, they're easily palpated. Now here we have avulsion. Avulsion is basically when a tendon of a muscle pulls that part of the bone out. So it causes the fracture of the bone by pulling the bone out itself. Not just, I broke my bone, so I have a bone fracture. No, avulsion is different. The tendon pulls the bone out, so, it just fractures it itself. Now, avulsion of what are we going to be talking about? This is the medial epicondyle. We're going to be talking about the avulsion of the medial epicondyle. When does that happen? A severe abduction force at the extended elbow or a fall on the extended elbow can cause this avulsion. Now, things that we need to know about the medial epicondyle avulsion is that the ulnar nerve is prone to getting damaged, so we might damage the ulnar nerve. And this part, as you can see, this is the medial epicondyle. It's supposed to be here. Like, okay, I get that it's fractured, but why is it being pulled down? So we have this ulnar collateral ligament. It basically pulls it down, pulls it distally. And for this injury, who are the victims of this injury? Most of the time, it's children or adolescents, since they have an incomplete fusion of the epiphyses. So if I don't tell you that it's a child or it's someone in adolescence, I just tell you, okay, patient comes to you with incomplete fusion of the epiphysis and has an injury around his elbow. What's most likely or most common injury that could happen there? It should be the avulsion of the medial epicondyle. Now, we have this elbow joint. You might think it's just two articulation, but no, it's actually three. We have two of them are hinge, and the hinge ones, as you can see, have humero. I have it in blue so you can, focus on that. Humero ulnar, so that would go with the ulna, and humero radial, that would go with the radius. And then we have this pivot joint. Pivot means that it moves like somewhat in a circle. It allows pronation, supination of the forearm. So this pivot joint is going to be the proximal radioulnar joint, And the humeral joints, humeral ulnar, humeral radial, these are going to be the hinge joints. So if you see in the MCQ, give me one of the hinge joints of the elbow, start looking with something with humeral in it, but make sure it articulates with one of the two bones down there. Just don't go for like what? Humeroscapular. Now for the movement, hinge joints, as we said before, do flexion extension. So they basically bring the forearm closer to the humerus and further away. You know, depends on which action you're talking about. Now over here, we're gonna talk about the pronation and supination. We're gonna talk in two positions. So in the anatomical normal position, where we're having our hands down, uh, when we do, pronation, the radial head is gonna be moving medially. So as you can see here, it's moving towards the ulna. So the distal end can cross. So the head would move medially and it would turn the palm posterior. As you can see, this is the palm, now it's posterior. We're looking at the dorsum. So uh, when we're in anatomical position, that's what happens. The head moves medially. But think about it. When we have a flexed elbow, we're not gonna have now medial and lateral. We're gonna have superior and inferior. So do the same action on yourself. You're gonna notice that the head is moving what inferiorly. So inferiorly when the elbow is flexed. For supination, just flip that. Instead of it being in anatomical position medial, it's going to be lateral. Instead of it going to be inferior in a flexed elbow, it's going to be superior. Now for the elbow capsule, it's basically just capsule around the articular margins, and then there's this recess. We're gonna call it the saxiform recess. It goes down, lines the inner capsule and the proximal radioulnar joint. As you can see here, it goes to the coronoid process anteriorly, and it goes to the olecranon fossa, not process, fossa, olecranon fossa posteriorly, coronoid fossa anteriorly. Now for the collateral ligaments, we have the radial one and we have the ulnar one. The ulnar one would be the medial one, and the radial one would be the lateral one. They're part of the capsule and they help, stabilize the joint during flexion extension. The ulnar collateral ligament goes from the medial epicondyle to the ulna. The lateral epicondyle to the annular ligament would be the radial collateral ligament. So the ulnar collateral ligament, medial epicondyle to the ulna, the radial collateral ligament from the lateral epicondyle to the annular ligament of the radius. Now over here we're going to talk about the elbow dislocation. Now in this capsule is very weak anteriorly. So when we have this posterior dislocation of the ulna and radius, just know that when it goes posteriorly to the humerus, this is most likely elbow dislocation. The the weak anterior capsule cannot hold the joint, so as you can see here, the humerus is kind of going anteriorly. Now what causes elbow dislocation? It can be hyperextension or a blow to the joint that causes it. One of the ligaments that gets injured is going to be the ulnar collateral ligament, which we talk about goes from the medial epicondyle to the ulna. Over here we have the associations, so things you might expect with elbow dislocation. We can have a fracture of the radial head, since the radial head would be right there. It can get fractured and just stay on there as it goes posteriorly. Or the olecranon, so the olecranon process of the ulna can just stay up there. Or we have the ulnar nerve. We said that the ulnar nerve is behind the medial epicondyle, and so it's in danger. If the ulnar nerve gets, injured, we're gonna have little finger numbness. We're gonna talk more about the ulnar nerve injury later on. Now, the annular ligament. It kind of completes the notch. So this is the radial notch of the ulna. It continues it in a circle. Make sure that it's a circle. Now, it is the deep surface of the ligament. So deep surface of the ligament would be lined with the synovial membrane, which is a continuation or distal continuation of the saxiform recess that we talked about. So the saxiform recess even continues over here. Now let's talk about the radial head subluxation. So subluxation means partial dislocation. So it's not fully dislocated, it's just partial. Now, in this scenario, which is very high yield, children are being pulled, their upper limb is being pulled upwards or being pulled by their parents or by anything. They have their limbs getting pulled upwards. So you hear, okay, upper limb getting pulled upward, That's most likely radial head subluxation. Now, other things that are in there, as you can see, the radius kind of just pops out and goes there. As it goes there, it can either cause a tear of this annular ligament, or it can basically, you know, kind of what is it called? Just like squeeze it between the radial head and the capitulum, and that causes the pain. So if it were to be trapped, if this ulnar collateral ligament was to be trapped between these two things, the radial head and the capitulum, it would cause severe pain. And I have that written in words for you over here. Now this is an X-ray. We have to get used to these stuff. You might see them in SAQ or whatnot. So this more prominent thing, that would be the medial epicondyle, and on the other side we have the lateral one. If we look at the bones, we can clearly see that this is the head of the radius, so this would be the radial bone. This would be the ulnar one. As you can see here, there's a fossa. It's just one, and that's most likely going to be the olecranon fossa since it's only one. And we have here the olecranon of the ulna. It goes into that fossa. If this is the olecranon, this part of the humerus would be the trochlea. This part of the humerus would be the capitulum, since this is the fovea of the radius. And over here, we have basically the coronoid process. We can't really see it from this view, but here, look at how you can see the proximal radioulnar joint. Look how they're articulating together. You can see that very clearly. Now over here, this is the lateral view. You can see the capitulum and trochlea, but I guess they're superimposed, so you cannot tell them apart, or you cannot really see them clearly. So you can just call that the condyle of the humerus. Here you have the olecranon, and here we have the proximal radioulnar joint. This is going to be the radius, and this is going to be, as you can see here, it's more clear. Here we cannot really see the coronoid process of the ulna. Here it's much clearer, and here we have the trochlear notch. The trochlear notch attaches to the trochlea of the condyle of the humerus. And I believe that's it for this lecture. Okay, so we're starting the questions. Here we have this scenario: a 4-year-old child. So that's a child. He fell from the stairs while his dad was pulling his arm up, and then he had pain in his elbow. So basically, parent pulling child's hand up. What was most likely damaged? I'm gonna reveal the answer in 1, 2, 3. The answer was the annular ligament. We talked about the subluxation. Let's move on to the other question. Here we have again another child lifted by her arms, and then she started feeling immense pain. What is most likely the cause of the pain? I'm gonna reveal the answer in 1, 2, 3. Okay, so the answer was separation of the head of radius from ulna and the capitulum. You might have been looking for, okay, what about it being trapped, about, the annular ligament being trapped between the radius and the capitulum? True, that would have been the more correct answer, but let's look at the other options. Compression of the median nerve. The median nerve is completely unrelated to this thing. Separation of the radius from the trochlea. The radius is not even articulating with the trochlea, but with the fovea. Here we have the separation of the ulna from the trochlea. Even though the ulna is attached to the trochlea, it is not related to the subluxation. Here we have stretching of the radial nerve behind the medial epicondyle. First of all, it's the ulnar nerve that goes behind the medial epicondyle, and it's the other side. The annular ligament is not on the medial one, but on the lateral one. And that's it for this lecture. We're gonna move on to brachial plexus. Okay, so now I'm gonna be talking about the brachial plexus. I'd like to start this out by, thanking my friend Faisal for helping me with the slides for brachial plexus, and you're gonna see exactly how he helped me. As you can see, we're gonna be explaining the brachial plexus from the roots. We're gonna be drawing it together, and this is the part that he helped me with. So let's start off by the roots of the brachial plexus. C5, C6, C7, C8, T1. So basically from C5 to T1, that's gonna be the roots of our brachial plexus. And then these roots help us form trunks. So we're gonna start with the superior trunk, and then we're gonna talk about the branches that come straight from the roots. So first one that I'd like to talk about is the dorsoscapular nerve. We know that goes to the rhomboids and the levator scapulae. And then another one that comes from the roots is the long thoracic nerve to supply our serratus anterior. It comes from C5, C6, C7. And now we have our trunks. C7 kind of just continues and gives us the middle trunk. C8 and C1 join together to form the inferior one. Now, out of these trunks, the only one that gives us branches is going to be the superior one. It gives us the suprascapular nerve, which goes over the suprascapular notch to innervate the supraspinatus and infraspinatus. And then we have nerve to subclavius, which, from the name, to subclavius. After that, these trunks give us divisions, anterior and posterior divisions. So that's one anterior, two anterior, three anterior, and then one posterior, two posterior, three posterior. All three posterior divisions join together to form our posterior cord. As we can see over here, this is the joining of the posterior ones in red. They're going to form the posterior cord. In green, we have the anterior divisions joining together to form us this lateral cord. And then in blue, we have the anterior division of the inferior trunk, giving us the medial cord. Over here, here is labeled. Now, for the branches that come out of these cords, we have the lateral pectoral nerve. It comes from the lateral cord. Lateral gives us lateral pectoral nerve. Very, it's very easy. And then we have the musculocutaneous nerve. As you can see here okay, so we have C5, it goes there to the musculocutaneous, C6, and C7. So in the musculocutaneous nerve, the root value of it would be from C5 to C7. Another thing that this cord gives, which would be the lateral root, which we'll just see right now, the lateral root. The medial one also does the same and gives us the medial root. Not only does it share the lateral cord by giving the medial root, but it also has its own medial pectoral nerve, which we said supplies both pectoralis major and minor. Other two branches that come out of it are the medial cutaneous nerves for the arm and the forearm. These are two different nerves, one for the arm, one for the forearm. And then it just continues as the ulnar nerve. So ulnar nerve has, the anterior division of C81. So that would be its root value. Now let's go to the last cord, the posterior cord. We have the axillary nerve and the radial nerve. These are terminal branches, or terminal, whatever you want to call it, terminal branches. The radial nerve has the root value of C5 to T1. But the axillary nerve, even though it should be like that, it's not. You have to memorize this. The axillary nerve is only C5, C6. So, if you're looking at solely the posterior cord, and we say, okay, patient comes to you with an injury that affects C7 and lower. So C7, C8, T1. Which nerve is most likely affected? And you look at the choices, you see, bunch of anything, and then radial and axillary nerve. Axillary would be incorrect since it's not affected. It's only C5 and C6. Radial nerve would be affected since it's all of them. Now, these are the terminal branches highlighted in purple, as you can see here. And then we have these three branches that come off the posterior cord, the upper and lower subscapular nerve. And we have this middle subscapular nerve, but I'd say go with the thoracodorsal nerve. It goes for the latissimus dorsi. The subscapular nerves, the upper and lower, they go to the subscapular muscle or subscapularis and teres major. Now let's talk about the cutaneous innervation. So when talking about the median nerve, we're gonna be talking about the lateral part of the palm. So the lateral 3.5 digits on the palmar surface, as you can see here, it goes to the dorsum of the tips of the finger and the nail beds. So that's all the palmar branch of it. As articular branches for the elbow and wrist, so anything that has articulation gets articular branches. Any muscle gets muscular branches. And it has a recurrent branch which we're going to talk about in the hand, or Khalid's going to talk about it again. Over here, we have the cutaneous innervation for the ulnar. It has a branch called the palmar cutaneous branch, which we said median takes 3.5 palmar fingers. This one's going to take the rest, which is going to be the medial 1.5 fingers on the palmar surface. And it has another branch called the dorsal cutaneous branch, and that just innervates the posterior 1.5 fingers. Now we're gonna talk about the deep branch. The deep branch of the ulnar nerve just goes and innervates, the intrinsic muscles of the hand, and has also articular branch, but only for the elbow, doesn't give the wrist, and has muscular branches for the muscles, such as flexor carpi ulnaris. Now I don't know why the picture is not showing, but I'm gonna explain it. The axillary nerve, it has this upper lateral brachial cutaneous branch for the upper lateral part of the arm. So look at your arm. Look at the upper lateral part of it. It is going to be innervated by this branch of the axillary nerve, not by the radial. Now, if you go over here, We're gonna be talking about the radial. So see this little pink part over here. If there was continuation of that, you'd see what the axillary nerve innervates, and over here under it, the lower lateral brachial cutaneous branch of the radial nerve innervates the rest. It also has a posterior cutaneous branch for the brachial one, and one for the anti-brachial, so that would be the forearm. And it has this superficial radial branch at the end, which gives us the innervation for the dorsum of the hand of the 3.5 fingers, because the median nerve did not cover those. It covered only the palmar side and the tips. So the superficial radial branch covers the rest. Now for the musculocutaneous nerve, we said that musculocutaneous, one for the muscle, one for the cutaneous part of the body. The muscles, it will be the flexors, so any brachialis you can think of, coraco, biceps, both heads. But the cutaneous branch goes to the forearm and helps us, with the innervation of the lateral part of the forearm. Now we have over here common fractures on the humerus. Let's start with the surgical neck fracture. In surgical neck fracture, we have damage to the axillary nerve and the artery that goes with it, which is the posterior humeral circumflex artery. Now, this is just a pop question for you. What space do these two exit out from? If you got it correct, you would have said the quadrangular space. Now, here we have this mid-shaft fracture. It would damage the radial nerve and the artery that goes with it, which is the profunda. Over here we have a supracondylar fracture, which only damages the median nerve. There is no artery that goes with it, so the only fracture with only a nerve being damaged, not an artery too, would be this one, and would be the ulnar one. So these two, no arteries with them. Fracture of medial epicondyle for the ulnar, supracondylar for the median. Here we have dermatomes. So I want you to look at your hand, make a fist, get your pinky out, get your middle finger out, and get your thumb out. And then starting from the thumb, I want you to count 6, 7, 8. Count every finger that's up. That's how you're going to memorize the dermatomes on your fingers. Okay? Now, what is a dermatome? It's basically an area of skin that is innervated by one dorsal root ganglia. But make sure you memorize C6, C7, C8. Now we have actions, or by the root. We're going to memorize them by the root. Starting with the shoulder. So if we're talking about the shoulder and it's doing flexion of the arm, lateral rotation or abduction, so basically we're making the arm move away, that's gonna be by C5. If we're bringing the arm back in, either by medial rotation or by adduction, that's gonna be C6, C8. There's this thing that one of the lab doctors told us, is that C5 is the nerve of flexion and C7 is the nerve of extension. So I think that's pretty applicable if we're talking from above the wrist. But when we go down the wrist, it's going to be a different story. Okay, so as you can see here, flexion, C5, lateral rotation. So anything away from the body, that's going to be C5. Medial rotation, adduction, that's bringing it back in. That's going to be C6, C8. Now we have the elbow. Again, flexion is going to be by C5, C6. Extension is going to be by C7, C8. If you had to guess what muscle does each of this action, so in the elbow, flexion, C5, C6, that would be the biceps, or the biceps biceps, yeah, brachii, and that would be innervated by the musculocutaneous nerve. Now, what roots of the musculocutaneous nerve? That would be these two roots, the C5, C6. Now, if we're talking about the tricep reflex, or tricep brachii, it's going to be innervated by the radial nerve, that's correct, but which roots to be specific? C7, C8. So when you're testing it, you're going to be testing these two roots, not the whole nerve. Now we have forearm. So C6 does pronation, C7, C8 does supination. Over here we have the wrist. We said the rule that C5 flexion, C7 extension. It's not applicable anymore. So in the wrist, C6, C7, so they do wrist flexion and extension. For the hand intrinsic muscle, it's going to be T1, which comes from the ulnar nerve. And then we have the digits. So flexion extension of the digits is going to be by C7, C8. So the wrist, we had flexion extension C6, C5, C6, or often C6, C7. And now we have flexion extension of the digits by C7, C8. So kind of just continue off of C7. Now we have the reflexes. I've already told you about this bicipital and tricipital reflex, but now it's just the forearm left. So we're gonna be testing the brachioradialis, which is gonna be, C5, C6 of the radial nerve. Now that's gonna be it for the lecture. You can memorize these yourself. صراحة, I don't think they're that high yield since we've just explained most of it. But now let's move on. We have questions. So I'm gonna reveal the answer in one, two, three. The answer is gonna be the suprascapular nerve. So we're saying there's a problem to initiate abduction, not to do the whole abduction. So that would be the suprascapular nerve, problem with the supraspinatus. If we were saying, okay, was unable to do abduction after getting the first 15 degrees, then that would have changed the whole question. The answer would have been axillary. Over here, we have someone with a mid-humeral fracture. This should be enough to get you to answer the question after long. Okay, which of the following nerves is most likely affected? I'm gonna reveal the answer in one, two, three. It is gonna be the radial nerve. We said the artery that goes with it also is the profunda brachial artery or the deep brachial artery. And that's it for the brachial plexus. We're gonna go with the arm and cubital fossa. Okay, so now let's talk about the arm and the cubital fossa. So, let's start with the fascia of the arm. So that's gonna be called, the deep fascia of the arm is gonna be called the brachial fascia. It has two septa coming out of it. One of them is lateral, one of them is medial, as you can see here in this image. This is gonna be the lateral one, it's shorter, and this is gonna be the medial one. It's gonna be longer. They attach to the medial and lateral supracondylar ridges of the humerus, and they, along with the humerus, they help divide it into the anterior and posterior compartment. They can even divide the fascia into the anterior and posterior facial compartments. Now, let's talk about this muscle, the coracobrachialis. Now, the coracobrachialis, from its name, coraco, the origin is going to be the coracoid process, and brachialis with the other brachialis in this arm. It's one of the flexors, and all the flexors are innervated by the musculocutaneous nerve, which has the root value of C5, C7. It causes flexion of the arm and adducts the arm, so brings it closer and then flexes the arm, brings it in front of us. It inserts into the middle third of the medial shaft of the humerus. Now, one thing that's special about this muscle is that this musculocutaneous nerve kind of goes through it. It goes into it, and this is very high yield, and I'm 100% sure it's gonna come as either an MCQ question or as an OSPI question because it was repeated in both. Now, let's talk about the biceps brachii. It has two heads, so it's gonna have two different origins, but at the end they have the same insertion. The first one, let's talk about the short head. It originates from the coracoid process. And let's talk about the long head. It originates from the supracondylar, supraglenoid tubercle. Now, how does it reach that supraglenoid tubercle? It goes to the bicipital groove and it just goes above there. Okay? It is also innervated by the musculocutaneous, flexes the arm and forearm, so brings the whole arm forward or brings the forearm, no, these bones closer to the humerus, and it causes supination of the forearm. It's one of the major supinators of the arm, of the forearm, not the arm. Now we have the brachialis. It originates from the anterior surface of the lower humerus, or you can call it, instead of lower humerus, distal part of the humerus, and then it inserts into the coronoid process of the ulna and the ulnar tuberosity. It's also supplied by the musculocutaneous, and what it does is that it flexes the forearm. Now over here we have the triceps. We have three heads. Triceps, three heads. We have this long head, which is in the infraglenoid tubercle. So over here would be the supraglenoid tubercle with the long head of the biceps. Under there, infraglenoid tubercle, long head of the triceps. Here we have, at the posterior part of the humerus, we have the lateral head of the triceps. And this lateral head is originating above the radial groove. Meanwhile, the medial head originates below the groove. And all of these are extensors, so they're gonna be, innervated by the radial nerve, and their job is to extend the forearm. They insert at the same point, which is the olecranon process of the ulna. Okay? Now another extensor I'd like to talk about is the anconeus. Very small muscle, it just assists in the flexion. Same innervation. It goes from the lateral epicondyle of the humerus towards the upper posterior surface of the ulna. Upper posterior surface. Now let's talk about the biceps. Any osteoarthritic changes or degenerative changes in the glenohumeral joint can affect the tendon of the biceps by rupturing it or even causing avulsion, which is the extreme one. And once that happens, when you try to contract the bicep, it'll form a belly. So the belly is gonna form a ball. The belly of the long head of the bicep is gonna form a ball. Now, let's talk about the skin innervation. The posterior surface is gonna be the radial nerve, and it even continues down at the end. Forget the inferior over here, I'm gonna fix it later. The medial surface, as we said in the brachial plexus, we have the medial cutaneous nerve of the arm. That takes care of the medial surface. The lateral surface, the superior lateral surface, is gonna be the lateral superior surface is gonna be by the branch of the axillary nerve, which is gonna be called the superior lateral brachial nerve. Now, by inferior here, I'm gonna add this to it so you guys are not confused. I mean the inferior lateral. So the superior will be here. This is the inferior. Okay. So inferior lateral of is gonna be innervated by the radial nerve. All right. I'm gonna make it clearer in the text once I'm done with this recording. Now, the arteries of the arm. We're gonna focus on the brachial artery. Now, it's a continuation of the axillary after passing the lower border, not the lower, the lateral border of the teres major. It is accompanied by two vena committantes, which are basically the two brachial veins, the deep ones. When we're talking about the proximal third, as you can see here, the brachial artery runs medial to it. But in the distal half over here, it's running anterior to it, and then it just goes deep to the bicipital aponeurosis. So it's under the aponeurosis into the cubital fossa, because this aponeurosis forms the roof of the fossa. Now, let's talk about the branches. You have the profunda brachial artery, so the deep one. That's gonna go with the radial nerve in the radial groove. We have the humeral nutrient artery. That's gonna supply the bone itself. We have muscular branches to the muscles. We have the superior and inferior ulnar collateral branches. And then we have these two terminal branches, the radial and the ulnar. Now, let's talk about blood pressure. When we want to measure the blood pressure, we use a machine called the sphygmomanometer. First audible spurt is the systolic one. So when you start hearing the spurts, the first one that you hear, that's going to be systolic. When it's released, which is the last, when systolic is released, you cannot hear the pulse anymore. The last one that you heard, that's going to be diastolic. And the normal thing is going to be 120/80. So they might drop you a whole scenario saying, okay, when you're using a sphygmomanometer, not that, okay, we're talking about blood pressure, and you started hearing some sound when the number on the scale showed 140, for example. So that's gonna be your systolic, and then you stopped hearing it when it got to, let's say, 90. So that's gonna be your diastolic. It would be 140/90. So be prepared for that. Now let's talk about Volkmann. Volkmann ischemic contracture. So from the name ischemic, so it should be due to an ischemic cause. So even though I've said let's not focus on the artery that goes with the median nerve before when we were talking about the supracondylar fractures, over here, once we're talking about the Volkmann, I want you guys to actually focus on it. Look at the bone over here. This is a supracondylar fracture. Okay? And what it does is that it causes the brachial artery to go into spasm. And not only that, it could affect the median nerve. So it can cause a problem in the median nerve, and it causes Volkmann ischemic contracture. Now, for the Volkmann, the cast can be too tight and can cause it. You could have compartment syndrome. We're gonna talk about that later. Or you could have just high pressure due to buildup of fluid, whether it is edema or a hemorrhage, which is bleeding, basically internal hemorrhage. Now, to control bleeding, so you see someone that's bleeding, we're trying to control it as much as we can, until, the ambulance gets there or something. If we're trying to control the bleeding with the subclavian artery, we press against the first rib, as you can see. Look at how he's pressing there. If it was axillary, we do the proximal humerus. If it was the brachial, it would be doing the distal humerus. So just memorize first rib, proximal, distal humerus. Now for the veins, we talked about the vena committantes or committants, whatever you want to call it. They're tributaries of the axillary vein, so they help form it. They're part of the things that form to join, to form it, join to form it. We have the basilic vein, which is the medial one. It becomes the axillary at the lower border. So this one is not a tributary, but it becomes that vein. And we have the cephalic one, which is lateral. It's another tributary of this axillary vein. Now, this is a cross section as you can see here. This is going to be the cephalic vein, so this is lateral. And then if that wasn't cephalic, then this one should be the basilic. It's gonna have some nerves running with it, and this one should be the radial since it's at the extensor compartment. The radial one is gonna have the deep brachial artery running with it. Over here we have the musculocutaneous nerve going through the coracobrachialis, and then we have the ulnar nerve goes with the basilic nerve, with the basilic vein. So over here. Now this is the cubital fossa. It's a triangular region. Over here we have the superior border, which is going to be the line joining these two epicondyles. Medially we're going to have the first flexor of the forearm, so that's going to be the pronator teres. And then laterally we're going to have the first extensor of the forearm, which is going to be the brachioradialis. I'm not sure why it's in the extensor lecture, even though it does flexion of the forearm. بس يعني خدوني عقد عقلي. Okay, let's move on. The floor laterally, so over this region, we'd be talking about the supinator muscle forming the floor, and medially over here, that would be the brachialis muscle. So supinator laterally, brachialis medially, and the roof is formed by the skin fascia. Then the strongest thing of the roof is going to be the bicipital aponeurosis. That's gonna allow us to do venipuncture. But not only is it the fact that we have bicipital aponeurosis, but also there's another reason that I'll explain in a bit. Now, let's talk about the deep structures in the fossa, in the cubital fossa. So, we have the median nerve, that's going to be the most medial, so this one would be the median nerve. We would have the brachial artery right there, so this would be the brachial artery. Then we would have the superficial branch of the radial nerve. I mean the biceps brachial tendon, then the superficial branch. So here we'd have the tendon, as you can see, and then the superficial branch of the radial nerve. Okay? So about this thing, Dr. Lennon tried helping us memorize it by the mnemonic MBBS, which is what we're studying right now, MBBS. So we're gonna start median nerve, that is most medial, median nerve. Then we have lateral to that is the brachial artery. Then more lateral, biceps brachii tendon. Then more lateral, the superficial branch of the radial nerve. Orient yourself with it because I'm sensing a question is gonna come from this. Sensing. So now let's talk about the superficial structures or the subcutaneous. So we said the lateral vein, that's gonna be cephalic. It's still here even after when when you go into the forearm. And then we have the basilic vein over here. They're joined together by the median cubital vein. The medial cubital vein has no nerves going with it. But the cephalic and the basilic, they do. So the cephalic has the lateral cutaneous nerve of the forearm, and the basilic has the medial cutaneous nerve of the forearm. So if you're trying to look for these, the lateral cutaneous nerve of the forearm, the medial cutaneous nerve of the forearm, look for these veins and it should be very easy. For the medial cubital vein, it has no nerves accompanying it. None. And the fact that it has no nerves, it helps us perform venipuncture. So the reason that we use this median cubital nerve is because the deep structures are protected by the bicipital aponeurosis, and no nerves come with it. So it's good for withdrawal of blood, IV transfusion, or IV feeding. Now we're done with the lectures. Pretty quick if you ask me. Now let's go for the questions. I'm gonna reveal the answer in 1, 2, 3. So through the mnemonic MBBS, you would have been able to tell the brachial artery, where is it? It is medial to the bicipital tendon, the MBBS. Median nerve, then we have the brachial artery, then we have the biceps tendon, then we have the most lateral thing, which is the superficial branch of the radial nerve. So medial to the tendon, to the biceps tendon, you will find this artery. Lateral to the artery, you'd find the biceps tendon. So, we have this question now. The musculocutaneous nerve pierces which of the following muscles? I'll reveal the answer in 1, 2, 3. It is the coracobrachialis. I've said that when we were looking at the muscle itself and explained it in the picture. And that's it for this lecture. Now we're gonna move on to the flexors of the forearm. Okay, so now we're gonna talk about the flexors of the forearm. Let's start this off by talking about the compartments. So we have an anterior compartment and a posterior compartment, same as what we said in the arm. So instead of having the brachial fascia being the one that divides it by, giving septas, it's going to be the radius, the ulna, and the interosseous membrane between them that divides it. The anterior part is going to be the flexor part, same as in the arm, and the posterior one is going to be the extensor part, again, same as in the arm. For the innervation of the anterior part, it's gonna be the median and ulnar nerves. Mainly the median one, it takes, most of the muscles there. And the posterior one is gonna be the radial nerve. Again, same as the arm. Now, let's talk about the action of these flexors on the wrist and the digits and, all of it, their actions. So at the wrist, from the name, their flexors, they're gonna cause flexion. So basically, we're bringing the palm towards the, whatever part you're seeing over here of the forearm. So this part, the anterior part, you're gonna be bringing it towards it. The ones with radialis in their name, so flexor carpi radialis, it would cause this radial abduction, so or radial deviation, which is, it's a better term for it. That would be abduction, since the radial bone is the lateral one. And then we have flexor carpi ulnaris. It would cause this ulnar deviation, towards the ulnar bone. Ulnar bone is medial, so we would have, adduction. And it causes, we have some pronators in there, they're gonna do pronation. Now, let's talk about the joints. We have the wrist, which is a condylar joint, same as the metacarpophalangeal joints. They all do the same action, which is flexion, extension, abduction, adduction, and circumduction. And then we have these interphalangeal joints. We have, proximal and distal. They also do flexion, extension of the digits, or between the digits, not of the digits. The anterior forearm is divided into three layers. We have a superficial one with 4 muscles, an intermediate one with 1 muscle, and a deep layer with 3 muscles. And we name those muscles based on what they attach to, how far they go, they're big or small, and their actions, what they do in there. So let's start off with pronator teres. If the name did not give it off, it is gonna be a pronator, so it's gonna pronate the forearm, and it's innervated by the median nerve, like most of the muscles in the anterior compartment. So in the superficial layer, the only muscle that is not innervated by the median nerve is going to be this flexor carpi ulnaris. It is going to be innervated by the ulnar nerve, and all these 4 muscles, they share the same origin, which is the common flexor origin at the medial epicondyle. Now, let's move on to the flexor carpi radialis. It's a flexor, so it does wrist flexion. Radialis, it does radial deviation, which is wrist abduction. It has the same innervation and the same origin. Now we're going to talk about palmaris longus. It does weak flexion of the wrist. That's not its main function, but what it does is that it tenses the aponeurosis over here. That's going to be on the palm, and it's going to help us do the gripping action. Now for the last muscle in the superficial layer, we have this flexor carpi ulnaris. From the name flexor, so it flexes the wrist. Ulnaris, it's going to do ulnar deviation, which is over here. It's going to be adduction. It is innervated by the ulnar nerve, and it's the only one in this layer, not in the anterior part, in this superficial layer, that is innervated by the ulnar nerve. Now over here, let's talk about the palmaris longus. It is not in everyone, so you could be missing it. You could have it. It's present on only 15% of the population. Over here, this helps you visualize this superficial layer on you. You go here to the medial epicondyle, which is going to be our common flexor origin, with the back of your thumb after you flexed it. And then you're going to lay out your 4 fingers on the anterior part of the forearm. You're going to say pass, fail, which is going to help you get the first letter of each of these muscles. We're going to have pronator teres at first. Then we're going to have flexor carpi radialis, because, we're more lateral, so we're closer to the radial bone. So that's why flexor carpi radialis would be there. Then we have palmaris longus. Then we have flexor carpi ulnaris, since we were so medial now. Now let's talk about the intermediate layer. It has one muscle in it, which is the flexor digitorum superficialis, and it has four tendons, as you can see. These tendons do not go all the way to the distal interpharyngeal joint, but it stays at the proximal one, so it has no effect whatsoever at the distal one. So it does flexion over here and flexion of the metacarpal phalangeal joints, so MCP and PIP. This muscle is innervated by the median nerve. Now, you might look at this and say, okay, why is superficialis in the intermediate layer? Well, that's because we have a profunda, flexor digitorum profundus, in the deep layer. Now, this flexor digitorum profundus, or this layer, afwan, this whole layer, it's no longer innervated by the median nerve itself, but a branch of the median nerve, which is going to be called the anterior interosseous nerve, or the deep branch of the median nerve. Okay, the name makes sense, the second one, not the anterior interosseous. Now, what this flexor digitorum profundus does, as you can see here, the one in the pink, that's the tendon of the flexor digitorum profundus. It goes all the way until the end. So it does the only action that the flexor digitorum superficialis can do, which is flexion at the distal interphalangeal joints. Now, we divided it into two halves since it's such a big muscle. This half is going to be our lateral half since it's closer to the thumb, and it is going to be innervated by the anterior interosseous, which is a branch of the median nerve. But the medial half, which is sitting on the ulna, it is going to be innervated by the ulnar nerve. Now, we have this muscle that goes to the thumb. It's exclusive to the thumb. It is going to be called the flexor pollicis longus. It goes all the way until the end, so it does help with flexion of this interphalangeal joint. There's no proximal or distal in the thumb since it has only one interphalangeal joint, two phalanges, so only one joint. And it has this metacarpal phalangeal joints, the MCP. It helps with flexion of that. And it is innervated by the anterior interosseous nerve only. Another muscle that shares the same innervation is going to be our pronator quadratus. As you can see here, it lies under them. And what that muscle does, from the name, it helps us pronate the forearm. And another thing that it does, it just brings these two bones together. So now let's talk about the golfer's elbow, or medial epicondylitis. Now it's basically inflammation or overuse of this of the muscles that are involved in this medial epicondyle or the common flexor origin. So repetitive flexion, pronation, they're gonna cause these changes in it to the CFO. So this the common flexor origin. So the patient will present to you with pain in that region, especially when they try to flex the forearm. I mean the wrist, not the forearm. So when they try to flex the wrist itself, they're gonna feel the pain, but not elbow flexion. So elbow flexion would be fine, but flexion over here at this region would cause pain. Same thing goes to pronation. Now, let's talk about the nerves. We have the median nerve. So to the anterior forearm, we have the median nerve and the ulnar nerve. We also have the radial nerve, which appears for some reason in the medial, in the cubital fossa as the superficial branch, but it does not innervate anything to the anterior forearm. It only innervates the extensor or posterior compartment. Now, let's talk about the median nerve. The median nerve passes anterior to the elbow, so anterior to the cubital fossa, and it goes distally with the anterior forearm. It innervates the superficial and intermediate layers except flexor carpi ulnaris, and then it gives us this the branch called anterior interosseous nerve, which is gonna go and innervate the deep layer, all of the muscles in the deep layer, and only half of the flexor digitorum profundus, not the full muscle over there. Here's the details about anterior interosseous in words if needed. And then this median nerve continues over here. We have this thing called the flexor retinaculum. The flexor retinaculum forms the roof of the carpal tunnel. So since this median nerve goes under it, it's gonna be in the carpal tunnel. Now, the ulnar nerve, it goes posterior to the medial epicondyle, which is why if you have avulsion or a fracture over here, it's gonna injure this nerve. It's gonna help innervate the flexor carpi ulnaris and the medial half of flexor digitorum profundus. Then it's gonna go continue down there. As you can see, this is our flexor retinaculum, but it's gonna go superficial to it or above it, and then it's gonna have its own canal. It's gonna be called the ulnar canal, or another name for that is Goyon's canal. Now, for the sensory branches, the median nerve gives us these 3.5 fingers in the palm, and it gives us this branch called the palmar cutaneous branch. As you can see here, this is the carpal tunnel, so this would be the flexor retinaculum. Before it goes in there, it gives us this palmar cutaneous branch for the center of the palm. So if a patient presented to you with symptoms of carpal syndrome, one thing that this patient is still gonna retain from this median nerve, it would be the sensation of the central part of the palm. So for the ulnar nerve, it gives us the palmar dorsal cutaneous branch of the forearm and the hand itself, and it gives us the palmar and dorsal, so two for backside, front side. Now let's talk about carpal tunnel syndrome. Tunnel itself, it has no arteries. It has nothing in there. It has nine flexor tendons. Four of them are superficialis, four of them are deep, and one of them is going to be for the thumb. And it's going to have the median nerve. Uh, if we have carpal tunnel syndrome, which is going to be compression of anything in this area, we're going to have problem with the 3.5 fingers over here, the lateral 3.5 fingers, but the sensation of the central part of the palm is spared because the palmar cutaneous branch of the median nerve is given before it goes into this tunnel. So now we have the blood circulation near the apex of the cubital fossa, so over here. The brachial artery divides into two, into the radial and the ulnar arteries. They both supply the extensors and then they continue to the hand, and the venous drainage would be basically the same same arteries. Now we have the antebrachial fascia, as you can see here. We had the brachial fascia over there, which was the deep fascia of the arm. Now we have antebrachial, and that's going to be the deep fascia of the forearm. Along with the interosseous membrane and these bones, it's going to help us separate the compartments. Now this fascia thickens and it forms this thing called flexor retinaculum, which we already talked about, but there is another name for the flexor retinaculum, which is the transverse carpal ligament. Now we have compartment syndrome. We've briefly, mentioned this before in Volkmann ischemic contracture. So this compartment syndrome is a cause of the Volkmann ischemic contracture. Now, when does compartment syndrome happen? When pressure is raised in this antebrachial fascia. So we have increase of pressure, it can cause this compartment syndrome. Why will we have this increase of pressure? Edema or hemorrhage can cause it, or maybe prolonged compression, such as in a tight cast. If this is untreated, ischemia is gonna go, it's gonna happen, and we're gonna have necrosis of the muscle, and it's gonna result in this Volkmann ischemic contracture, which is permanent flexion of the wrist and the fingers. So we're done with the lecture. Let's go over questions. The FDP is innervated by which of the following nerves? I'm gonna reveal the answer in 1, 2, 3. Now the answer is gonna be both A and C. It is not directly by the median nerve itself because it is in the deep layer. It is by the anterior interosseous branch of the median nerve and by the ulnar nerve. Now we have this question about golfer's elbow. So I'm basically asking you, what is golfer's elbow? I'm gonna reveal the answer in 1, 2, 3. The answer would be an inflammation or injury to the CF, the common flexor tendon or common flexor origin. They're the same thing here. Why is it not A? Because this says extensor, if you did not focus on that. So now that's it. We're gonna move on to the extensors of the forearm. Okay, so now we're gonna be talking about the extensors of the forearm. Now we've already talked about the antebrachial fascia. We divided it into anterior and posterior, but now we're gonna focus on the posterior compartment. It is divided into two layers. Superficial one that has 6 muscles, and then deep one with 5 muscles. So that's a total of 11. While the anterior one had 4, 1, 3, which would sum up to 8. So the first muscle, brachioradialis. Now, even though it's an extensor, it does flexion of the arm, and it is one of 2 muscles that is innervated by the main trunk of the radial nerve. It originates not from the common extensor tendon, but from the lateral supracondylar ridge. And as you can see, the tendon continues, even though the muscle stops, to the styloid process of the radius. Now, this is the other muscle that is innervated by the main trunk of the radial nerve, which is extensor carpi radialis longus. It also originates from the lateral supracondylar ridge and from the common extensor tendon. So mainly it would be the lateral supracondylar ridge, but anything that affects the common extensor tendon would affect this extensor carpi radialis longus. If we follow the muscle, as you can see here, I'm going slowly so you guys can follow up. It goes into this part of the second metacarpal. This is what we call the base of the metacarpal, and that's the dorsal surface. So that's the dorsal base of the second metacarpal. What it does is from the name extensor, so extends, and radialis, radial deviation. This one is the brevis. It does the same action, but now we're no longer innervating these muscles by the main trunk, but by this branch called the posterior interosseous branch. Here is the muscle. Let us follow it, and it ends up on the third metacarpal at the same, dorsal base, but now it can be called posterior base. Same action as we said. If you want to see, it's like right here under the longus. So this is brevis. We have removed the longus so you can see it clearer. Now, extensor digitorum muscle. It's for the second to fifth digits. It originates from the lateral epicondyle or the common extensor tendon. It goes to the extensor expansion and base of the middle digital phalanges. Okay. It is innervated by the posterior interosseous branch of the radial nerve, and what it does is that it does extension of the fingers and somewhat of the hand. Now, even though we have digitorum for all fingers, digiti minimi has its own extensor as well, which is extensor digiti minimi muscle. It comes from the common extensor tendon and the interosseous membrane. And what it does is just focuses so you can extend the pinky by itself. It is innervated by the posterior interosseous nerve and just extends the little finger as its action. What's so cool about this is that if you try to like extend the ring finger, you'll notice that the middle one is slightly moving with it. Or if you try to do the opposite, the other ones are slightly moving with it. But if you do it with the pinky, it is so much easier to extend it without moving the other fingers because of this extensor digiti minimi muscle. Now this is just a fun fact, not something that you need to know for the exam. Helps you memorize it. Now we have extensor carpi ulnaris. Extensor, so it's gonna extend the wrist. Ulnaris is gonna do ulnar deviation, so adducts the hand. It is, if you follow the muscle, it inserts into the base of the fifth metacarpal, and it originates from the same common extensor tendon and the posterior surface of the ulna, and the lateral epicondyle. Now we have tennis elbow. For the flexors, we had golfer's elbow and it was medial epicondylitis. Now we're gonna have tennis elbow, lateral epicondylitis. When does it happen? When you do a lot of forceful extension and flexion of the wrist. It's usually, we're gonna have a strain in the common extensor tendon. We're gonna inflame that tendon, and you might inflame the periosteum too. So that would be the covering of the lateral epicondyle. Will inflame that. And that's it for tennis elbow. The muscles that are affected are all the extensors in the superficial layer except brachioradialis, since it comes from the lateral supracondylar ridge only. It has nothing to do with the common extensor tendon. Now, let's talk about the deep layer. We have this muscle which is called the supinator. Supinator originates from like 5 things. It has the lateral epicondyle as one of its origins. It has this radial collateral ligament as another one of the origin. It has this annular ligament which goes around the radial head as one of its origin. And that's like it for the ones that don't make sense. Like I don't know why it's originating from there. But one that makes sense is gonna be the supinator fossa from the name supinator. So it's gonna have supinator fossa as its origin. And the crest of the ulna, as you can clearly see here, it goes from there. And now this muscle moves over here and inserts into the lateral side of the radius. So when it contracts, it's gonna help us supinate the arm. Or the forearm, not the arm. So now let's talk about the muscles in the deep layer. Starting with abductor pollicis longus. It's an abductor. So it would end up at the lateral surface of the first metacarpal. That's its insertion. And its origin is going to be from the posterior surfaces of the ulna and the radius and the interosseous membrane. And from its name, what it does is that it does abduction of what? Of the pollicis and somewhat with the hand. Okay, someone with the hand. It helps with the thumb extension some way too, but there is a muscle for that. I want you to focus that the abductor comes from the radius and the ulna, while the extensor comes from the ulna alone, the longest, and then the extensor brevis comes from the radius alone. So I want you to keep that in mind as we go through this. They're gonna share every other origin except this part that I've highlighted in red. The insertion over here is gonna be the distal phalanx. So over here, it would be doing extension at the interphalangeal joint of the thumb, and it's gonna extend the thumb itself. Now, the brevis, as you can see, the brevis kind of goes from the radius only into the proximal phalanx, which is this one. So it's gonna help us with the with the extension of the metacarpal phalangeal joint, the MCP joint or MP. Now, for the deep layer, we've done with the thumb. We're still going over this. We have the extensor indicis muscle. It goes from the, it originates from the posterior surface of the ulna. So this is the radius, this is the ulna, posterior surface of the ulna, and this membrane between them, which is the interosseous membrane. If you follow it, it goes and it inserts into the extensor expansion of the index finger only from the name indicis, index finger. And what it does is that it extends the index finger at the metacarpal phalangeal joint, the MCP joint. So when you're doing the shahada while you're playing, that would be the action of extensor indices. Now for the anatomical snuff box, it's basically depression in the lateral surface of the thumb. You can, see it on yourself. We're gonna talk about the borders. So over here, this is the lateral border, which is more straight on the thumb. So the one that you're gonna see more clearly on your hand is gonna be this lateral border. That would be the extensor pollicis brevis mainly, and even more lateral to that is extensor pollicis longus. But to be more specific, if these two came in the MCQ, always pick the brevis, the extensor pollicis brevis, since it's more, in contact with the snuff box. Snuff box is over here. This is the brevis. The, abductor is over here. And then we have the medial border, which is going to be over here. It's going to be the extensor pollicis longus tendon. And we have the floor under there. You're going to see two carpal bones. One of them, the scaphoid, which is in the proximal row, and the other one is going to be the trapezium, which is in the distal row. We're going to talk about them in the next lecture. Now we have the contents of this. Snuff box. So superficially, we have the cephalic vein and the superficial branch of the radial nerve. And in it, we have the radial artery or branch of the radial artery. So it can go and supply the dorsum of the hand, so the back of the hand. Now, we have the radial nerve itself. We're going to talk about the posterior interosseous branch, which supplies all the extensors except the main two, the first two that I talked about, which are the brachioradialis and the extensor carpi radialis longus. They're supplied by the main trunk, not by the posterior interosseous. Now, we have this thing called the entrapment syndrome. Entrapment syndrome, when there is hypercontraction of specific muscles, it can, compress the nerves that go through them or can affect the nerves that go through them. So, the first one that I'd like to talk about is going to be the supinator muscle. It's going to have its effect on the posterior interosseous nerve. For the other one, we're going to talk about the flexor carpi ulnaris, and this one we know it very clearly. It is innervated by the by the ulnar nerve. So flexor carpi ulnaris, if it were to contract, it would affect this. It would affect this nerve. As you can see here, just to help you guys see it, this is the deep branch of the radial nerve, which is also known as the posterior interosseous. It goes into the muscle. So if that muscle were to contract, it would compress it. Here is the ulnar nerve. Flexor carpi ulnaris, it's cut over here, but if it were full and it were to hypercontract, it would compress this. And then we have the pronator teres, which goes from the medial epicondyle over like that. As you can see here, the medial nerve runs under it, even though it's cut, as you can see here. So if it were to hypercontract, it would affect this nerve. Please memorize these muscles and the nerves. They're very high yield, and we're so getting a question from here. Now we have the radial artery. The radial artery is going to go onto the brachioradialis, and then we're going to have this thing over here called the radial pulse. We're going to be able to feel it over here. Medial to the radial pulse, we're going to have the flexor carpi radialis tendon, and lateral to it, we're gonna have the tendon of the brachioradialis. So, if you were doing this radial pulse and I ask you which is the medial tendon, you should say the flexor carpi radialis tendon. Which is lateral to this, this radial pulse, you should say the tendon of the brachioradialis. Focus on the tendon part because they might try and trick you and put the muscle itself. Now, the radial pulse not only can it be felt in this region, but as you can see, it continues in the anatomical snuff box. And if it continues there, it's gonna have two different tendons on it. So the tendon, the medial one, would be the extensor pollicis longus to that thing. It would be and the lateral one would be the extensor pollicis brevis. Okay, same as the borders of the anatomical snuff box. You can say also that the abductor pollicis longus, but EPB it's closer. Now the radial artery gives us all these branches, gives us muscular branches to the muscles, gives us cutaneous branches, radial recurrent branches, which we'll talk about in the hand, and then carpal branches again in the hand, and deep palmar arch. This is very, very important in the hand, and Khaled will take, and talk about this a lot. So, now we have the ulnar artery. It is in the middle of the forearm and it is joined by the ulnar nerve. So at first the ulnar nerve has no artery with it, and then as it continues over here, it gets this ulnar artery and it joins it. Okay? It goes deep, as you can see it going deep to this flexor carpi ulnaris, and it distally goes with this tendon. Okay, with the flexor carpi ulnaris tendon. It goes lateral to it. So here would be the thumb, here it is lateral to it. The flexor carpi ulnaris tendon is medial. Now, the ulnar pulse, as we said, it is lateral to the flexor carpi ulnaris tendon. And if we look at here, oh, we have 4 tendons. What muscle has 4 tendons? It would be the flexor digitorum profundus. So that would be the medial part, or what's medial to the ulnar pulse. So, ulnar artery, as we said, passes as it goes down into the hand. It goes lateral to the pisiform, pisiform carpal bone, and it goes superficial to the flexor tenaculum. We've mentioned the Guyan's canal before, but now just add on it lateral to pisiform. Okay, so these are the branches. It has anterior and posterior recurrent branches. As muscular branches, it has this common interosseous, which gives us the anterior and posterior interosseous arteries. It has carpal branches, and it has the superficial palmar arch. Radial had the deep palmar arch, ulnar has the superficial one. Now, this common interosseous, it's a short branch and it divides it into these two. It's common, it's gonna be dividing, obviously. Now, the anterior, it's gonna go to the, it's gonna give us this median artery to the median nerve, and it's gonna continue descending with the anterior interosseous nerve to supply the flexors of the forearm. And if you could take a wild guess, what does the posterior interosseous supply? It's gonna supply the extensor of the forearm. And what nerve does it go with? Again, the posterior interosseous nerve. Okay, so we have this thing called Allen test. What we do is that we press on both the radial and the ulnar pulse, and we look out for the color. So we press on them, the patient, makes a fist, and we'll look at the return of color. If the color returns back quickly, then that's a good artery. If it takes time, then you might be experiencing something. So let's talk about the arteries here, the collateral circulation. So I want you to take this, any collateral artery, it's gonna continue and anastomose with the recurrent one. So over here we have the superior one, as you can see here. The inferior would be right here. The superior ulnar collateral artery continues. It goes. Oh, it's going back. So it makes sense that it would be anastomosing with the posterior ulnar recurrent. Okay, so collateral with recurrent. Again, you can see that again for the inferior one. Inferior is over here. It goes to the anterior. See how it's not going behind the medial epicondyle? It's going anterior to that. That's why it's the anterior, not the posterior one. Now, we have the radial collateral. The radial collateral, as you can see here, continues anteriorly. It goes to the radial recurrent, so that's pretty easy. بظلوا لنا آخر تنتين, these last two, they go together, the middle collateral and the interosseous recurrent. So it's always a collateral with a recurrent. Now, let's talk about the veins. We have 4 deep ones, but two names. So two radial and two ulnar. When these join together, they'll form our two brachial veins, or the two vena comitants. So these here that we can see, these are gonna be our superficial veins. We're gonna have the basilic one and the cephalic one. Cephalic is gonna be more lateral, it's closer to the thumb, and the basilic is gonna be more medial. And they continue as these same veins up until they become the axillary. In the middle, as you can see here, in the cubital fossa, they're gonna be joined by this median cubital vein. Now, we're done with this lecture. Let's go over the questions. I'm gonna reveal the answer for this question in 1, 2, 3. As you can see here, we're talking about the radial pulse. We're asking what is medial to it. It is going to be the flexor carpi radialis tendon. Now, over here, to check the pulse, so we're checking the pulse in the snuff box. Which pulse would that be? Again, radial pulse, but it's in the snuff box. Now, I'm going to reveal the answer in 1, 2, 3. So the medial one would be the extensor pulsus longus. Instead of thinking about the radial pulse, you can think about the anatomical snuff box itself. And then to our last lecture, it's gonna be A17. It's gonna be the bones and joints of the wrist and hand. Okay, so now finally into the end of this crash course, or the first part of this crash course, we're gonna be talking about the bones and joints of the wrist and the hand. So, we're gonna talk about the distal radioulnar joint, which basically allows us to do supination. So this one would be the proximal one, as you can see here, the radial notch and the head of the radius. Over here we have the head of the ulna and the ulnar notch of the radius. So as you can see here, the ulnar notch, it's on the radius itself, and here we have the head of the ulna in it. So this part can flip over it, okay? The ulnar notch is on the medial side of the distal humerus, and this is the head. It's gonna help us with pronation, supination. So, for pronation, as you can see here, the bones are crossed each other. So the distal end is gonna go anteriorly and it's gonna go medially. So, anterior medially over this bone, over the ulna. While in supination, it's gonna go the opposite, so it's gonna go laterally and it's gonna try to uncross it. So it's again gonna follow it laterally, anteriorly. As you can see here in the picture, this one would be supinated, this one would be pronated, because we can see the crossing. The crossing mainly happens at the end. So, the region of the hand. Now we're going to talk about these 8 carpal bones, these 5 metacarpals, and the 14 phalanges. The thumb has 2 phalanges, not 3 like the rest of the fingers or digits. So we're going to have a total of 27 bones in the hand. Now, for the carpals, we have 8 of them, and we're dividing them into 2 rows. We're gonna have a proximal row and a distal row. If you were to look at it posteriorly, so it would be this surface. It would be convex, as you can see here, it's coming out. But if we were to look at it anteriorly, which would be this part over here, or the part that we're looking at in this picture, that would be concave. So it has, space for the tendons and the median nerve to go through this carpal arch. Now, the carpals. The proximal row is scaphoid, lunate, triquetrum, and pisiform. This is from lateral to medial. So let's go over here. This is going to be our scaphoid over here. That's most lateral scaphoid. And then we move over here more medially. That's going to be our lunate. Even more medially is going to be triquetrum. And sitting on top of the triquetrum or anterior to the triquetrum is going to be our pisiform. We said that lateral to the pisiform. Medial to the pisiform, lateral to the pisiform. We're gonna have Guyon's canal, which is gonna be also superficial on the retinacula, flexor retinacula. Now, let's talk about the distal row from medial to lateral. So we're gonna have here hamate. So, and that's the hook of hamate, but we're gonna have hamate here. With the hook of hamate, we have a nerve that goes here, which is gonna be the ulnar nerve. So a fracture of the hook of hamate is gonna also cause, damage to this ulnar nerve. We have the biggest carpal bone in both rows, which is gonna be our capitate. The biggest one in the proximal row is gonna be the scaphoid. We have this trapezoid and we have this trapezium. I don't know why, they said it looks like a table, so they called it trapezium. And this is, a bit rounded off, so it's a capitate. This is a hook, so no wonder why hook of hamate. They said that a scaphoid looks like a ship. I don't see it, but sure. Lunate, it's called lunate because if you look at the other surface, you're gonna see that it kind of has a C shape or اللي هو زي الهلال. Okay? Triquitrium, I don't know why they named it Triquitrium, and Pisiform is just this, P on top. Okay, so let's talk about the scaphoid fracture. This scaphoid bone, it is the most commonly fractured carpal bone, and there's something unique about its, blood supply. So we have this here, this palmar carpal branch. It is part of the radial artery or a branch of the radial artery. As you can see here, it doesn't directly innervate it, supply it, but it goes distal, supplies the distal part, and then it goes back in front to the proximal one. So if it was, fractured at the waist of the, of the scaphoid bone, the proximal part can go into a vascular necrosis. Over here, the proximal portion ends up with a vascular necrosis. Now, look at this lunate shape. Look at how you can see the curve of the moon, which is called like lunate or the C shape. That's why it's called lunate. It is the most commonly dislocated bone. So when you hit it on like let's say anything and you fall on it, it gets displaced into the palmar surface. So that would be the anterior one. I don't know why if you get hit on the anterior surface it still gets there, but it's about biomechanics. We don't really need to know that, but just know that lunate dislocates anteriorly, so to the palmar surface. What happens when it goes there? It goes and compresses the median nerve, causing carpal tunnel syndrome. Here are just what I just said in words. Now let's talk about the hook of hamate injury. The Guyon's canal runs there, lateral to the pisiform, and the floor is made by the flexor retinaculum. So injury to this hook of hamate is going to cause damage to this ulnar nerve at the distal portion of it. Okay, so now let's talk about the five metacarpals. It has a base which is proximal, has a shaft, and has a head which is distal. The head articulates with the phalanges, and the base articulates with the carpal bones. Some sesamoid bones can appear at this joint over here, the first metacarpal joint. So some sesamoid bones can appear here. Now we have phalanges, 3 per digit except for the thumb. It also has a base, shaft, head, and in the same order. The base articulates with the proximal, with either the metacarpal. So let's talk about this proximal phalanx. The base with the metacarpal bone, the head with the other phalanx, okay? And then the distal phalanx has this expansion over here at the distal end to form, the nail bed. Over here we have that in picture in case you want to get oriented with it. Here we have the proximal row with the scaphoid, lunate, triquitrium, and anterior to it is going to be the pisiform. The distal row, the five metacarpals with the first metacarpal having sesamoid bones that they're not in everyone, and then we have the phalanxes or phalanges. Over here we have it in X-ray. The phalanx are pretty clear, the metacarpals are very clear. As you can see here, this is the distal radioulnar joint, and the styloid process is just like the most distal part of the bone. That is pretty clear too. Now for the carpal bones, they're the ones that are so important. So the one, let's look at the thumb. The one that articulates with the first metacarpal is always going to be trapezium. I like to start with this metacarpal, which is the first metacarpal. I know that trapezium is always under it, and the one that's under the trapezium is going to be the scaphoid. Now, near the scaphoid, we're going to have lunate, and then we can continue off the proximal row to, triquitrium and pisiform. Let's go forward. We have the hamate with its hook over there. We have this capped off, this bone that has a cap on it. That's going to be the capitate, and it's the biggest one. And then we have the trapezoid over here. Make sure that you memorize all of these bones. Now, let's talk about the wrist joint, which is the radiocarpal joint over here. When we talk about it, it does, the main movement of the wrist. It's a condylar joint. We have the intercarpal joints. These are, not much movement over there. The carpal-metacarpal joints, we can say the same over here, not much movement. Metacarpophalangeal joints, it's another condylar joint that does movement. And then we have the interphalangeal joints, which are hinge, does flexion extension. Let's take them one by one. Radiocarpal joint, we already talked about it. Now, the radius, it articulates with the whole proximal row except the pisiform. So the only bone that does not articulate, as you can see here, this is the, here we have the scaphoid, lunate, triquetarium. Pisiform gets none of that articulation. And as you can see here, the ulna itself does not participate in this articulation, but it has this articular disc, and this is very high yield. The articular disc takes and articulates with these carpal bones instead of the ulna itself. That's why when you're trying to do ulnar deviation in your hand, it has much more range than when you're doing radial deviation, because it does not directly articulate with them. Now, for the radicarpal joints, we have, abduction, adduction, extension, flexion, and circumduction. But we're not gonna be focusing on the circumduction. Now, for the abduction, we're going laterally towards the radial bone. So any muscle with radialis in it, you know that it does abduction. Adduction, we're going towards the ulnar bone. So any muscle with ulnaris in it, it does adduction. Now, extension, any extensor. Flexion, any flexor with palmaris longus, which is one of the, flexors over there. That's not present in everyone. Now, we have the intercarpal and carpometacarpal joints. They're plain joints with the exception of the first carpometacarpal joint, which is a synovial saddle joint with the thumb. These plain joints, they just do gliding. That's it, gliding. The first metacarpal joint, it's the first metacarpal with the trapezium. It is saddle. It has like a concave surface and a convex one. If you go with this blue line, that's gonna be our concave surface. And if you go with this red one, that's gonna be our convex surface. And this joint allows, this shape allows a lot of movement in there. So, when you do this L-shaped, you're gonna be extensing the thumb. So, let's go over here. Wait, we'll talk about the thumb again in a minute. So let's now talk about the metacarpophalangeal joints, MCP joints. Over here, flexion, extension. Now, they're condylar joints because they can also do abduction, adduction. Okay? Now, we'll talk about these muscles that facilitate these two movements in hand 1 and 2. So, that's going to be in the following lecture. Not done by me, but by Khalid. Now, let's follow on. This interphalangeal joint, it does flexion extension only. It's a hinge joint. We have the proximal one and the distal one done by two different muscles. They're hinge synovial joints. So we have this transverse carpal ligament or the flexor retinaculum. Through it we have the carpal tunnel that has these following tendons in it, the flexor tendons. Anything that causes thickening or compression of this tunnel causes carpal tunnel syndrome, which is compression of the median nerve. And that's it. But let's go back. I want to explain this thumb movement. So if we're going from the index finger upward, that's gonna be extension. If we're going from this position downward towards the palm, that's gonna be flexion. Okay? Now, if we were going away from the palm, like not up, but away towards, like towards the screen, orient yourself the same way as this L, and then go towards the screen. That would be abduction of the thumb. That would be abduction, moving there. But if we were doing, from that position, we're bringing it back in, that would be adduction, okay? So again, I'm gonna explain this. Orient yourself like this L on the screen. If you move the thumb downward, so we're moving the L back, bringing it towards the index, that's gonna be flexion. If we're bringing it back to the L, that's gonna be our extension. If we move the thumb towards the screen, that would be abduction. If we're moving it back towards the original position, that's gonna be adduction. Okay, I hope that was clear. Let's go on to the question again. So we're asking which is most likely fractured over here. I'm gonna show the answer in 1, 2, 3. It's gonna be the scaphoid bone. Bonus question: what's most likely going to happen to the proximal part of the scaphoid bone? Your answer should be avascular necrosis, because if it's a mid fracture, then okay, that's it. The proximal one is not getting, it's not getting supply because of the retrograde supply of the blood supply to the scaphoid bone. So let's go on to this question. It looks a bit long, but you gotta get used to that because not all of it is the question or what we want. I'm gonna reveal the answer in 1, 2, 3. It's gonna be the articular disc. The question was, which of the following structures normally articulates with the distal end of the ulna at the wrist joint? We know that the ulna itself does not articulate with the carpal bones, but it's خلاص the articular disc of it. That's gonna be it for this crash course. The second part is gonna be done by Khalid. I hope this was nice. I hope you know you guys have a good study, and that's it.